Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, Pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. We've got your free 31-page PDF on the top 200 medications. Absolutely a no-brainer to have if you're out in practice, if you're going through pharmacology classes in school. Great little refresher and or study guide that can help you learn pharmacology a little bit better. So, go take advantage of that at reallifepharmacology.com. All right, mixing it up a little bit today by request, we are going to take a deep dive into NSAID drug interactions. So, non-steroidal anti-inflammatory drugs, common medications include ibuprofen, naproxen, diclofenac, and so on. There are lots of different NSAIDs. I want to talk about some of the most important drug interactions you're going to see because, let's face it, these medications are used very frequently, especially when you consider the fact that, a couple are over the counter. We've got ibuprofen, we've got naproxen. Patients can pick these up, not recognize, not understand that there can be significant consequences and interactions if we take these medications with other medications. So, I'm going to highlight some of the most important things here that you should pay attention to and things that I've seen in practice. So, first and foremost, hypertension is obviously a really, really common condition. NSAIDs have the potential in their ability to inhibit prostaglandin synthesis to impair the effectiveness of antihypertensive medications, and they can cause sodium and water retention. So when you retain sodium, when you retain water, you have the potential to raise blood pressure, and NSAIDs can do that and directly oppose what we're trying to do with antihypertensive medications like ACE inhibitors, diuretics, beta blockers, calcium channel blockers, ARBs. These are all potential issues, all potential medications that can have their effects counteracted by the use of NSAIDs. So if you've got a patient in practice that has resistant hypertension, for example, and we're adding blood pressure medications, we can't seem to get it down, nothing seems to really be that helpful, or it's very difficult to get down, that's a situation where we definitely want to look at that medication list and make sure that they're not taking an NSAID, for example. Okay? All right, next interaction, I'm going to stick with cardiovascular a little bit. I do want to talk about NSAIDs' risk for heart failure. So I alluded to that risk of sodium and water retention. That can be problematic in heart failure and kind of directly oppose what we're trying to do with diuretics and also have an additive effect in the edema situation to like a medication like amlodipine, which can worsen edema. Another good example are the gabapentinoids, like pregabalin and gabapentin. So these are all medications that can exacerbate edema, and NSAIDs can interact and have that additive effect of worsening that water retention, sodium retention, and exacerbating heart failure in those type of patients. So definitely another one to pay attention to there. Next, definitely got to cover anticoagulants, antiplatelet medications. So NSAIDs themselves inhibit platelet function. In addition to this, they can irritate the GI tract, the gastric lining, if you will. And this can ultimately increase the risk of bleeding. Most specifically, GI bleed risk is going to be the highest because of that potential to irritate the GI tract. So this is one of the reasons why we always give NSAIDs with food, is because they irritate the GI tract. So in patients taking anticoagulants, antiplatelet medications, let's say, clopidogrel, for example, anticoagulants, warfarin, DOACs like apixaban, we really want to do everything we can to try to avoid the use of NSAIDs in those patients because that bleed risk, most specifically the GI bleed risk, will go up significantly. All right, the next one I want to talk about is in relation to renal function. You may often hear this referred to as the triple whammy on the kidney. So that would be NSAIDs in combination with ACE inhibitors or ARBs and diuretics. So this is definitely a combination that is very common. I have seen it. We really, really got to be careful in relation to renal function with this combination. So basically, NSAIDs inhibit cyclic oxygenase, or COX, which reduces the synthesis of certain prostaglandins. Those prostaglandins normally dilate the afferent arteriole. So that's the incoming blood vessel to the glomerulus. That's the main unit, the main functioning unit of the kidney. So when that's inhibited by NSAIDs, the afferent arteriole actually constricts, which reduces that glomerular perfusion, so that flow through the glomerulus, and ultimately alters that filtration pressure. So that's what NSAIDs can do. So then ACE inhibitors, they actually block the renin-angiotensin-aldosterone system, which normally causes the efferent arterial constriction. So by blocking angiotensin 2, this causes the efferent, so that's the one going away or out of the glomerulus, that causes dilation, thus lowering glomerular filtration pressure. So you can see how that, kind of that combination on each side of the glomerulus can impact that filtration pressure and essentially cause it to reduce function or potentially even stop functioning if it's severe enough. And then the third effect from diuretics is, recall that diuretics essentially increase urinary sodium and water excretion. So it kicks water, it kicks sodium out. So that causes volume depletion. So that effect on the kidneys, we essentially have reduced circulating volume in the vasculature, and that can lower renal perfusion pressure to the glomerulus and the kidney itself. So you basically get three medications working together in a negative fashion on the perfusion of the glomerulus, or the kidney, if you will. You get those three medications working together in a negative fashion, and that glomerular filtration pressure can essentially go way down. And this is going to increase the risk for acute renal failure, likely shown in an elevation in creatinine. So again, together, these three classes of medications drastically reduce glomerular filtration pressure, impairing that renal function, and can potentially cause acute kidney injury. All right, moving on, let's talk a little bit about NSAIDs and SSRIs. So NSAIDs, obviously, I alluded to the fact that they can inhibit platelet function as well as damage GI mucosa. So SSRIs do have the potential to reduce platelet serotonin uptake, which can impair platelet aggregation, so potentially making the blood a little bit thinner. Now, from a clinical standpoint, is this something I really, really get worried about? So if somebody's on, maybe a lower dose SSRI, I'm probably not quite as concerned about it. However, if they're reporting, bleeding, if they've had GI bleed history, we've got to have a little higher flag on that. Now, as you escalate dosages of both the SSRI and the NSAID, then I start to kind of get a little bit more serious about it and worry a little bit more about it. So definitely something to pay attention to. Now, would I worry about fluoxetine 10 milligrams compared to using an anticoagulant like apixaban? Okay, my level of concern for the low dose fluoxetine is generally much lower in clinical practice compared to the use of an anticoagulant like warfarin or apixaban. Okay, so that's kind of how I look at it on scale. But that's not to say that you shouldn't worry about it at all. Okay, so definitely one to think about, and definitely one that comes into play quite a bit because we have a lot of patients on SSRIs as well as NSAID. All right, so NSAIDs and aspirin. So obviously that, bleed risk can potentially go up with that GI irritation. But I want to mention aspirin specifically because there is some potential that non-selective NSAIDs like ibuprofen, for example, can compete with aspirin for COX-1 binding, reducing aspirin's antiplatelet effect. Okay, so essentially this can lead to a reduced cardioprotective benefit of aspirin, which we commonly used, post-MI, stroke, those type of things. So this is a little bit controversial, but there has been some evidence to say that giving aspirin at least 2 hours before the NSAID may help in reducing the risk for this interaction and still help get the antiplatelet action that we're trying to get with the aspirin. All right, moving on, we've got NSAIDs and lithium. So NSAIDs can actually reduce lithium renal clearance by reducing renal blood flow and sodium excretion. So what can result is an increase in lithium concentration. So recall lithium used for bipolar disorder. So some signs and symptoms of toxicity if you encounter this interaction. Lithium toxicity can present as confusion, tremor, ultimately can worsen renal function as well. Can have some GI upset, nausea, and vomiting as well. So quite a few different signs and symptoms of lithium toxicity. But I think it's definitely important, very, very important, to educate our patients taking lithium that they should avoid NSAIDs if at all possible, but at least consult a healthcare professional first before considering the use of NSAIDs. If it's felt that we absolutely need both in combination, what we're probably going to do is obviously clinically monitor that patient closely, making sure that they're not displaying signs and symptoms of lithium toxicity. The other thing we're going to think about here is making sure that we check a lithium level. So hopefully we've got a baseline at some point where they're at on their stabilized dose. Checking a level, we can see if those levels have gone up with the use of those NSAIDs. All right, now probably to some of the less common ones, I guess, if you will, maybe things that I've seen less frequently. So methotrexate, I'll mention. So NSAIDs do reduce the renal clearance of methotrexate by inhibiting renal prostaglandins. And, again, ultimately those methotrexate levels could go up. So we've got an elevated risk of methotrexate toxicity. Another one I have seen come into play is corticosteroids and NSAIDs being used together. Again, not incredibly common. So let's say in something like a rheumatoid arthritis flare, we typically only use one. So we'll use an NSAID to treat that, or we'll use corticosteroids. We typically don't use both. But if you do have a situation where a patient is using both of these together, they can definitely have that additive effect on the gastric, on the GI tract, and increase the risk for GI ulceration and bleeding. The other thing I think about is nephrotoxicity, so NSAIDs themselves. I alluded to the triple whammy with ACEs and diuretics and NSAIDs. I do pay attention to other nephrotoxic agents as well. So if you've got a patient taking, let's say, cyclosporin, maybe aminoglycosides, these are nephrotoxic themselves, and in combination with NSAIDs, we may increase that risk a little bit further. So obviously want to use lower dosages, minimal length of time if possible, and of course if combinations of drugs to the kidney are absolutely necessary, we feel like we need to use them, we have no other options, obviously we're going to monitor that renal function closely as well. All right, and the last medication I want to mention with NSAIDs is digoxin. So NSAIDs can reduce the renal clearance of digoxin, kind of similar to methotrexate. This is more true in patients with already compromised or impaired renal function. patient population that I work with, most commonly, this may be more at risk, or those patients may be at higher risk there of renal impairment, so geriatric patients, for example. This combination could lead to an increased risk of digoxin levels and ultimately digoxin toxicity, increase the risk for arrhythmias, visual disturbances, weight loss, GI upset. Those type of things are signs and symptoms of digoxin toxicity. All right. Well, if you enjoyed this episode, please do me a huge favor. Support the sponsor, meded101.com/store. We've got tons of resources there, including things on drug interaction as well. But if you're looking for pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, and so on and so forth, again, go check out meded101.com/store. Your purchases there go directly to support this podcast. If you'd be so kind, share this podcast episode with friends, colleagues, anybody who could benefit from some pharmacology and drug interaction information. I greatly appreciate that. Leave us a rating review on iTunes or wherever you're listening. Hopefully you found this episode helpful. If you have other suggestions for topics, questions about study materials, different books I have, things like that, don't hesitate to reach out. mededucation101@gmail.com. You can also connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. I hope you enjoyed this special episode today. Take care, and hope you have a great rest of your day.